PadmavathY. She is the chief and head of the neuro-ophthalmology department in Aravind Eye Hospital, Tirunelveli since 2005. She has won many best paper awards in TNOA and All India conferences, and she has been a reviewer of instruction courses and many free papers in All India and Tamil Nadu conferences. And she is going to talk about supranuclear pathway and disorders. Over to you, madam.
A very good afternoon. At the outset, I would like to thank Dr. Kalaimathi for giving me this opportunity and honor to deliver a lecture in KSOS. Back 2 years we were on online. I think this is the first time I am giving an offline lecture. The topic assigned to me was a supranuclear pathway and palsies. Actually, this cannot be covered in 15 minutes. But still, I'll try to do justice for the speech. Many times, I think everyone would have wondered, why do we require eye movements? In order to keep our vision steady, you need to fixate at a target. So, in order to focus, your point of precision should be on the fovea. And you have to have a main fixation to view the object clearly. Apart from that, there are many activities which are going, you tend to read. You just ask the letter or you scroll the letters, you tend to see an eye movement. Apart from that, have you ever wondered, when you walk, still you are able to read the book clearly? What makes you read the book very clearly? So there are different mechanisms in our neural mechanisms which help us to maintain our vision steady. One is your vestibulo-ocular reflex, which even during any rotation, you are able to fixate on a target. The next is you are fixating on the target to view it properly. Apart from that is your optokinetic nystagmus. So all these, what do these things do? They hold the images on the retina. View this video. You can see a boy seeing a thumb. He is fixating on the thumb. He is moving to one side and he is moving to the other side. So what are the systems or what are the movements associated with it? One is your pursuit. You are following a target. As the target is moving, you are moving the object. That is the pursuit. The next is your saccadic system. When you look at one target, suppose someone comes, you tend to do a corrective movement. So that is a saccadic system. Apart from that, when you are focusing, your vergence system comes into play. So these movements direct the fovea to object of interest. Okay. So whenever you have a limitation of movement, the commonest thinking is it is the nuclear level palsy. So what happens is whenever you have a nuclear association, the muscle is palsied. But there are certain conditions where the nucleus is under the control of supranuclear centers. So I am going to be speaking about these supranuclear as well as the internuclear. In order to look horizontally, what makes you to look one side? Suppose I want to look to the right. What is the center? It's your parapontine, the horizontal gaze center. It is called the parapontine reticular formation, which is in the pons. So this is the one center which coordinates your eyes to look to the right. To right, it is the right PPRF. For the left, it is the left PPRF. Suppose you want to look vertically. What is the center? This center is situated in the midbrain, which you call it as a rostral interstitial nucleus of the medial longitudinal fasciculus. It is in the midbrain. So this center coordinates your eyes to move vertically as well as torsionally. Coming on to the horizontal gaze pathway, you have if you want to look to the left, your left PPRF should be stimulated. But the command has to come from the right frontal field. I'm sorry. So the command comes from the right frontal field to the left PPRF, from which it goes to the sixth nerve nucleus, which innervates the left six lateral rectus. Through the MLF, it is the innervation also goes to the medial rectus. So this is the horizontal gaze saccadic pathway. So any affection in along the pathway has a limitation of movement. For the vertical gaze, as I said, there is a different pathway for the upward as well as the downward saccades. One, from the RMLF, you have through the fibers going to the oculomotor nucleus, that is the elevators of the same side for upward gaze. So it is a bilateral representation, one to the same side elevators and also to the contralateral superior rectus as well as the inferior oblique. For the down gaze, you have from the RMLF, you have the excitatory burst neurons which innervate on the same side. The inferior rectus nucleus on the same side, oculomotor nucleus, and the superior oblique of the nucleus on the same side. So the muscle will be the opposite, the nerve will be the other side. Before you, in order to look to one side, you have certain neurons within the PPRF as well as the RMLF. You call them as the excitatory burst neurons, which stimulate the motor neurons to fire so that the agonist muscle goes into the proper position against the what you call as against the forces of the muscles as well as the orbital pull. So from the excitatory, you have the impulse which is going on to the agonist muscle. At the same time, if you are looking to the right, your right lateral rectus, what happens to the other muscles, your right medial rectus as well as the left lateral rectus? Someone has to say, you don't function, this is functioning. So you have the inhibitory burst neurons, which is going to the antagonist muscle, which doesn't allow to function. Always the excitatory burst neurons is not going to be fired. If you are going to have continuous firing of the excitatory burst neurons, you are going to have more amount of bizarre movements. So this is something under the control of the omnipause neurons. So the omnipause neurons will not function when there is a saccade. After the saccade is generated, it is going to get reduced. In order to maintain to that position, you need to have something of a frequency of a pulse, and in order to maintain in that position, you need to have a step or something which is maintained. Suppose I want to look to the right. To the right, if I am looking, there are certain centers which I will try to maintain my gaze on the right. So what is the structures which is involved in making you look to the right or maintaining? To look to the right, your PPRF is functioning. To maintain to look on the right, you have something called as the neural integrators. This is different for the vertical as well as the horizontal. For the vertical, it is the interstitial nucleus of Kajal. For the horizontal, it is the medial vestibular nuclei. So moving on to the saccades, which is one of the fastest eye movements. It is a conjugate eye movements which brings the object of interest onto the fovea. Suppose you see a picture, you make multiple saccades to view the image. Whenever you examine any neuroophthalmic case or whenever the patient presents with diplopia, it is mandatory you see the ductions as well as the versions as well as the vergence. So as you see the saccades, you have to have between 30 to 40 degrees apart two targets. You have to measure horizontally as well as vertically. You have to see the latency, velocity as well as the accuracy. How accurate it stops short of the target. The next is your pursuit. The pursuit is a system. This is a slow eye movement where you track a object. Suppose you are moving, still you are able to track an object. There is one entity which is the vestibulo-ocular reflex. When you try to rotate, even then you are able to focus on the object. So this is a smooth pursuit. You have to see how smooth it is initiated and how it is following the target. The pathway for pursuit is a bit complex, where you perceive the objects in motion, which goes to the visual cortex. From there, it through the magnocellular pathway in the lateral geniculate body, it goes to the striate cortex, then goes to the parietal cortex. From there, it is into the projects to the frontal eye field and medial superior temporal field. There is actually here, this is a bit complex. There is always a double decussation, one to the cerebellum from the vestibular nucleus to the horizontal gaze center. So this is how it is followed. The next is your vestibulo-ocular reflex. This is the reflex act which connects the balance organs and eye movement structures. This keeps our vision steady when we move by moving, whenever we move instantaneously our eyes in the direction opposite. Suppose you thrust your head to one side, your eye movements goes to the other side. So what are the structures involved in that? You have the semicircular canals as well as the otolith organs. The three semicircular canals which are responsible for the angular vestibulo-ocular reflex, which includes when you turn your heads to the side, up and down. The next is your otolith organs, which is the saccule as well as the utricle, which is involved in your linear vestibulo-ocular reflex and ocular tilt reaction when there is a movement with turning with respect to gravity. These are the things which are going to, suppose you tilt your head and you're moving, or when you are driving in a car, you are able to visualize the things properly. So the vestibular nuclei, it is always connected to the oculomotor nuclei. One is the third and fourth to move the eyes vertically as well as torsionally, and sixth and third to move the eyes horizontally. This keeps our vision stable and you are able to maintain a visual horizon whenever with whatever position you make with your head. The next is your optokinetic system. This is tested predominantly by the foveal fixation and pursuit. This actually complements the vestibulo-ocular reflex. This is usually with a handheld drum, black and white stripes. You should test it horizontally as well as vertically. Next is your vergence, which helps in depth tracking of an object. This is governed by the parietal occipital frontal lobe, which increases with age. The midbrain lesions usually cause a convergent defect, whereas pontine lesions cause a divergence defect. So we'll move on to the abnormalities of the saccade. Whenever you say the abnormalities of the saccade, it could be any saccadic oscillations, intrusions, or initiation, or any abnormal latency. If you see this video, the movements are a bit slow. You are not seeing a pursuit. This is actually a saccade. It is a slow saccade. So this is an abnormal velocity which is often seen in a spinocerebellar ataxia type 2. Watch this girl who presented with abnormal eye movements. When you give a target, she doesn't move her head, she thrusts her head to see the object. Yeah, that's right. So this is a case of congenital oculomotor apraxia, which you call it as a Cogan's oculomotor apraxia. Here you have an increased latency, or you could call that as a saccadic initiation failure. The newer terminology is saccadic initiation failure. These head thrusts are there to trigger the vestibular guided saccades. And moreover, this is associated with several diseases. The location of the lesion is not known. Apart from that, you can have square wave jerks, opsoclonus, etc. The next is your gaze palsies. See the head turn of this elderly lady with hypertension. She was a 60 years old female with hypertensive etiology. She had a face turn to the left. If you can see, she is able to move up, but to the right she is not able to move. If you can see, there is a facial palsy also associated with it. So this is a case of right horizontal gaze palsy. This is at the level of the nucleus. So you have a lacunar infarct in the parapontine formation. This is a PPRF. If you can see how is it differentiated from a nuclear lesion. The right gaze is not there. To the left, the eyes are moving. But if you see through the vestibular ocular reflex, you are able to perceive to the other side. So the differentiation is you tend to have loss of ipsilateral horizontal eye movements as well as voluntary saccades and involuntary saccades. Smooth pursuit and vestibular ocular reflex are spared here, whereas here you have an associated facial palsy. You can see the abductive nystagmus. This is a case of internuclear ophthalmoplegia. I think I'll take another 5 minutes. Is that okay? Or if I can stop short, I'll stop short. Okay, fine. So whenever you have a lesion in the PPRF, you have a saccadic palsy. When you have the lesion in the sixth nerve, it is a gaze palsy. In the MLF, it is internuclear ophthalmoplegia. Bilateral MLF, it is a wall-eyed bilateral internuclear ophthalmoplegia. With the PPRF MLF, it is 1.5 syndrome. This is a video of a patient who has a vertical gaze palsy. He is not able to look up. You can see the saccades are very poor. Down also he is not able to see. He had an infarct in the midbrain. Okay, I think. So bilateral lesions are usually common, usually associated with infarct of the posterior subthalamic artery. So when you have the lesion in the posterior commissure, you have upward eye movements affected, down gaze deviation and downbeat nystagmus. So when you have pursuit abnormalities, whenever you have in this area, it abolishes the smooth pursuit, whereas in the frontal eye field, it is an impaired ipsilateral pursuit, whereas in the medial superior temporal, it is a decreased velocity and amplitude. When it involves the cerebellum, it is impaired ipsilateral pursuit. The gaze deviations, where you send horizontal or it could be vertical, when it is to the same side, it is in the frontal lobe. If for seizures, it is to the opposite side. Pontine lesion, it is to the opposite side. Vertical deviation, you tend to see in post-encephalitic Parkinsonism. You call that as an oculogyric crisis. So convergence insufficiency, you see usually in Parkinsonism as well as progressive supranuclear palsy. You can see the patient is not able to follow the target. The pursuit is almost very slow. So you can call that as a saccadic pursuit. Here the convergence is also very poor. So this you call that as a progressive supranuclear palsy, where your vertical gaze paresis is worse for downward than superior. And the pursutic saccadic, it is called. You tend to have absent convergence as well as OKN, which may be diminished. The last is when you have an affection of the cerebellar thing, the saccades are hypermetric, or you can call it as a dysmetria, where it is overshooting the target. So it could be a saccadic dysmetria, pursuit, or it could be unstable fixation. You tend to have an vestibulo-ocular suppression in these cases with gaze-evoked nystagmus. To conclude, you have to identify the characteristics of the ocular movement, correlate with associated neurological findings and neuroimaging. Thank you for your patience here.